Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. They will be very useful to fourth year students in oral exams, theory exams, as well as when they go for private practice. Today, in continuity with the previous lecture series of neurology, today we'll be discussing on one of the very short topic, that is how you approach to the person who has got muscle weakness, because muscle weakness can be there in case of generalized causes, neurological causes, as well as because of muscle disorders. So pertaining to that, we are going to discuss mainly on the muscle disorders. So we always say that localization of lower motor neuron lesion, particularly related to muscle, we include in that myopathy groups. Here I am not going to discuss regarding myoneural junction, that is myasthenia gravis group, but will be just talking little bit in more detail on myopathy. So first step is always to identify the pattern of weakness, and in that we divide into three big groups. We call cerebral cortex and corticospinal tract, which will end up with upper motor neuron type of motor weakness, and anterior horn cell and peripheral nerves, peripheral motor nerves will produce lower motor neuron type of motor weakness. And we have got another two group of disorders where nervous system is not involved, that is myoneural junction and disorders of muscle. So you can have a motor weakness because of upper motor neuron damage, because of lower motor neuron damage, or because of myoneural junction, and because of muscle disorders. So this will be four big groups: upper motor neuron, lower motor neuron, myoneural junction or neuromuscular junction, and muscle. We'll be concentrating on muscle. So weakness, you can have upper motor neuron, lower motor neuron. Upper motor neuron will be with peculiarity, that is increased tone, brisk reflexes, clonus present, plantar extensor, or we call Babinski sign. While lower motor neuron will be because of damage to anterior horn cells or nerve root or peripheral nerve, that will be lower motor neuron. And in that particular, you will have decreased tone, that is hypotonia, wasting, fasciculation. Reflexes will be absent if there is a damage at the level of reflex arc, and plantar reflex will be normal and it will be absent if there is a damage at the level of alpha S1. But plantar reflex will be flexor if there is a damage other than alpha S1. And we'll have a fourth group of disorder, which will be neuromuscular junction and muscle disorder, where you will have no involvement of cortical signs, cranial nerves will not be involved, and you will have no sensory involvement. You will have only muscle weakness and muscle involvement. So upper motor neuron involvement can be hemiparesis, can be paraparesis, quadriparesis, or can be abnormal, bizarre distribution of weakness. And whenever you get a bizarre weakness, you can suspect some of the odd disorders like multiple strokes, multiple sclerosis, motor neuron disease, and there is one more, neuromyelitis optica. So this will be the different group of disorders which can produce bizarre distribution. But specific distribution like hemiparesis, monoparesis, quadruparesis, etc. we are not going at present. That will produce upper motor neuron type of lesion. And here in this also you will have upper motor neuron, but it will be a bizarre distribution. While lower motor neuron you will come across in case of a myoneural junction, muscle and anterior horn cell with up to myoneural junction. Now, in this too, there will be no sensory involvement, while in anterior horn cell also there will be no sensory involvement. But if there is motor involvement with sensory involvement, then it will be other group of disorders like Guillain-Barré, peripheral nerve, then disseminated lesions, involvement of multiple peripheral nerve like peripheral neuropathy, and here this is called dermatological distribution. Depending upon the dermatomes, that will be root involvement, or we call as plexopathy or radiculopathy. We will not be talking on this side, we will be talking on this particular two only, and mainly in muscle. And in muscle you can have polymyositis, dermatomyositis, myopathy, that is proximal myopathy, and we also include one more, inclusion body myopathy, and you can have other conditions like alcohol, statin, which will be acquired group, which will be among acquired groups, and that will be related to the muscle disorders. Now, if you have got acute onset, unilateral, and with upper motor neuron signs, cortical signs involved, cranial nerves involved, always we suspect cerebral cortex or we suspect corticospinal tracts. If it is in the distribution of dermatome distribution, we'll always suspect nerve roots. And if you have got sensory plus motor and in the distribution of peripheral nerve, we'll suspect peripheral nerve involvement. So you look at those particular findings and you will be able to differentiate from other groups. Now, whenever you get the involvement of the myoneural junction, where you will not have any mental status involvement, no sensory involvement, bladder involvement will not be there, you will have no cranial nerves involvement. When you get all those findings, either it is myoneural junction or muscle. So stroke will produce unilateral weakness, sensory loss, dysarthria, aphasia, ataxia, etc. And that will suggest cerebral cortex or corticospinal tracts. Myelopathy and chordoequinal lesion will produce paraparesis or quadruparesis, back pain, bladder and bowel involvement will be there in case of chordoequinal lesion. And you will also saddle anesthesia depending upon where is the lesion. So myelopathy and chordoequinal lesion will be involvement of the spinal cord, that is lower end of the spinal cord. We call myelopathy and chordoequinal lesion, where you will have those peculiar. While in Guillain-Barré, you will have a bilateral, symmetrical, rapidly progressive, ascending variety, and both motor as well as mild sensory symptoms. That will be peculiar in case of a Guillain-Barré, and it will be post-infectious group. While myasthenia gravis will be diffuse weakness, no sensory symptoms, eyelids are involved, and extraocular muscles are involved. So ptosis, ophthalmoparesis producing diplopia, and it will be a fluctuating weakness. Person will feel better with rest, and person will have increased muscle weakness with the use of muscle. So that will be very peculiar in a myasthenia gravis. While an example of West Nile disease, it will be diffuse patchy weakness because of involvement of the brain, no sensory involvement. It will be preceded by febrile illness. There will be GI symptoms. There will be meningeal symptoms. And person will have very frequently what we call as encephalitis. So we always have muscle weakness because of two major disorders. We already mentioned upper motor neuron and lower motor neuron. In upper motor neuron, you will have power diminished, hypertonia or rigidity. We usually use the word spasticity. Reflexes will be brisk and clonus will be present, and plantar reflex will be extensor. And there may be disuse atrophy, but fasciculation will be absent. While in lower motor neuron, muscle wasting, fasciculation, power markedly diminished or almost we say zero, tone, severe hypotonia or flaccid paralysis, reflexes will be diminished or absent, whichever muscle is being involved, and plantar reflex will be flexor or absent if there is a damage at the level of alpha S1. And we should be able to differentiate now myopathy from anterior horn cell, which is a lower motor neuron. Myopathy is a variety of a lower motor neuron, but we don't use the word lower motor neuron. We say muscle involvement. Peripheral neuropathy is also lower motor neuron, but it is the involvement of a peripheral nerve and myoneural junction. So all these three will produce lower motor neuron type of involvement. In short, myopathy will have a proximal muscle weakness, while in a neuropathy it will be a distal muscle weakness. Deep tendon reflex will be preserved in myopathy, while because of involvement of the reflex arc, you will have a deep tendon reflex being affected depending upon the nerve involvement. And there will be sensory finding will be always present in case of neuropathy, while in case of a myopathy, sensory system is normal. So in general, if we want to differentiate between these four groups, because these are the four groups which are very different, very close differential diagnosis whenever you get muscular weakness and of lower motor neuron variety. So in case of myopathy, it is usually proximal, symmetrical. Atrophy will be there in an early stage and it will further increase as the stage advances and you will have a severe muscle atrophy. Usually fasciculation are not common. Fasciculations are absent. Reflexes, if the muscle is severely involved, it will be diminished or absent. Because there is no involvement of the reflex arc, so reflexes are usually present. But if the muscle is very badly involved, you can have loss of reflex also. In case of myositis, you can have pain in muscle region. Person may also complain of cramps. Sensory involvement is never present. It is always normal. Sensory findings will be normal. And CPK invariably in a myopathy, particularly in case of myositis, traumatic myositis, etc. or traumatic myopathy, you will have involvement of muscle and you will have CPK markedly elevated. In anterior horn cell, it is as the involvement of anterior horn cells. It is usually distal muscle which is being more involved. You will have asymmetrical, very, very common. You will have a severe muscle atrophy right from the beginning. Fasciculation will be almost always present. Whichever anterior horn cell taking part in a reflex, they will be diminished or absent. Pain is usually not present. Cramps may be present. Sensory system is not involved, so sensory findings are normal. And occasionally you might have, because of wasting, you might have little amount of CPK being elevated. While in peripheral neuropathy, it is bilateral, symmetrical and distal. Atrophy is usually less, but in a severe peripheral neuropathy, you might get a muscle wasting. Fasciculation may be present. Reflexes, depending upon the nerve involvement, if it is concerned with reflex arc, it will be lost. Pain, usually it is more of paresthesia, and in some cases person may complain of even hyperesthesia. Cramps may be present. Sensory is always involved. Person will have a loss of sensation in the area of involvement of the nerve distribution. And CPK will be normal because muscle is not very commonly involved. While in myoneural junction, it is mainly involvement of the extraocular muscles, eyelid muscles, and mainly proximal muscles. Atrophy is absent, fasciculation is absent, reflexes will be normal, pain is usually not present, cramps are usually not present, sensory system is normal, and CPK is normal. So this will be the very important difference in these four groups, which mimics in lower motor neuron variety, where sensory system is usually absent except in a peripheral neuropathy. So in anterior horn cell, myopathy and myoneural junction, sensory findings are absent. So if you get a sensory finding with lower motor neuron variety, do suspect peripheral neuropathy. And if sensory system is normal, there is muscle involvement, there is lower motor neuron type, suspect myoneural junction or anterior horn cell disease or myopathy. So any person who comes with a muscle weakness, if answer is yes, first always look whether it is localized or generalized. If it is localized, then we proceed further in this particular, but if it is generalized, always rule out cachexia, one of the very common cause in India because of malnutrition, tuberculosis, HIV, etc. Thyrotoxicosis. In all those groups, you will have severe muscle wasting, and in that person can have muscle weakness, even in old age person. And also, you can come across in myasthenia gravis in a late stages and hypokalemic or hyperkalemic periodic paralysis. But in that also, usually we don't have a generalized but more of localized in periodic paralysis. If there is no muscle weakness, now person can mimic in cardiopulmonary disorders like cor pulmonale, anemia, chronic infection, malignancy, depression, arthritis, fibromyalgia. They might complain of muscle weakness type of symptoms, but it is not truly involvement of the muscle. But if it is a localized muscle weakness and if it is asymmetrical, always suspect stroke, cerebrovascular disorders, demyelinating disease, compressive neuropathy like carpal tunnel syndrome, radial nerve compression, sciatica, tarsal tunnel syndromes, etc. Or mononeuritis multiplex, which are very common in diabetes, disuse atrophy, myasthenia gravis, etc. But if it is symmetrical and if it is proximal, we always suspect myopathy, particularly Duchenne and Baker's myopathy, that is muscular dystrophy, and myasthenia gravis. If it is distal, we do keep it in mind, peripheral neuropathy, motor neuron disease, and in late stages of myasthenia gravis. And if there is a specific pattern, it will be muscular dystrophy like Duchenne or Baker, which is a proximal or we call limb girdle myopathy, and there are many other variety of other myopathy. You can come across some of the hereditary neuropathy, myasthenia gravis, and inclusion body myositis group also. This will be in general. So if you come across upper motor neuron type of muscular weakness, suspect motor cortex and corticospinal tract involvement. But lower motor neuron, spinal nerve root, peripheral nerve, myoneural junction, muscles, this will be the four common. Always try to rule out this: anterior horn cell, spinal nerve root, peripheral nerve, myoneural junction and muscle. Totally 5. So do keep it in mind. Anterior horn cell, nerve root, peripheral nerve, myoneural junction and muscle. So always rule out between these 5 groups, and I've already discussed 4. Peripheral nerve and nerve root, there is a little difference. In a nerve root, you will have a root pain and there will be involvement along the dermatomes distributions rather than peripheral nerve distribution. Two simple differences between the two. So upper motor neuron stroke and corticospinal tract involvement. While lower motor neuron, you can have radiculopathy, polyneuropathy, or it can be mononeuropathy. That will be another group. And you can have muscle involvement like muscular dystrophy, polymyositis, then steroid induced hypothyroidism, hypoglycemia, hypokalemia, etc. So this will be myopathy groups. So we have to always keep it in mind: anterior horn cell involvement, radiculopathy, neuropathy, myoneural junction and muscle. So myoneural junction, myasthenia gravis example, Lambert-Eaton syndrome is another example, and also you can have curare poisoning or botulism. So whenever person comes with a muscle weakness, I've already mentioned, you must rule out upper motor neuron from lower motor neuron. And once there is a lower motor neuron type of findings, then we go for differential diagnosis in the form of myopathy, myoneural junction, anterior horn cell, radiculopathy, peripheral neuropathy, etc. And whenever we get that, we don't have altered level of consciousness, cranial nerves are not involved, except in case of brainstem cranial nerve involvement because of disorders like Guillain-Barré syndromes, motor neuron disease, demyelinating disease, etc. Sensory system is not involved in person who comes to you with an anterior horn cell involvement and myoneural junction, myopathy. But sensory findings will be there if you get lower motor neuron finding due to radiculopathy, spinal nerve roots and peripheral nerve. In that, sensory finding will be there. Atrophy will be very common in lower motor neuron, but in case of a muscle, there is a group of disorders where we get pseudo hypertrophy or we call hypertrophic disorders like Duchenne and Baker's. Fatigue will be a very common symptom. Pain will be more common in myositis. Statin induced myopathy. Also sometimes we come across in case of a hypothyroidism and even in a vitamin D deficiency. Cramps may be very common in some of the muscle disorders or we call myopathic groups of. Contracture will be quite common in case of a muscle disorders. Myotonia will be common in a disorders where there is a myotonic group of disorders which are genetic disorders, one of the variety of myopathy. Usually in a myopathy, you have got a proximal muscle more involved as compared to distal, and good number of time it is symmetrical, while in case of a myoneural junction, it is asymmetrical, and in case of a peripheral nerve and radiculopathy, it is a distal muscle more involved as compared to proximal muscle, and even in case of an anterior horn cell, distal muscles are more involved as compared to proximal muscle. Reflexes, by and large, in case of a muscle disorder, myoneural junction disorders, reflexes will be preserved and normal unless that group of muscle is being involved which is concerned with reflexes. In case of peripheral nerve also, because reflex arc is broken and even in an anterior horn cell damage or in a case of radiculopathy, because the reflex arc is broken, the reflex whichever is involved with that distribution, that reflex will be absent. In case of lower motor neuron, in case of an anterior horn cell involvement, you will have a muscle wasting and fasciculation present. Also, in case of a peripheral neuropathy, you can have a muscle wasting and fasciculation. But in case of a myopathy group of disorders, muscle may be wasted in case of early stages of myopathy, but fasciculation may not be seen in those particular groups because it is not involvement of anterior horn cell or peripheral nerves. CPK level will be markedly elevated in the myopathic groups, particularly polymyositis as well as myopathy. But CPK level will be normal in case of peripheral neuropathy, also in case of what we call as myoneural junction also. CPK are usually normal. In case of myositis, particularly polymyositis and myopathic group of disorders, CPK level will be markedly elevated. Plantar reflex will be normal in case of myopathy, myasthenia gravis, that is myoneural junction. But plantar reflex may be absent if there is a anterior horn cell damage or neuropathy involving alpha S1 or radiculopathy at the level of alpha S1. Then plantar reflex will be absent. But plantar reflex will not be extensor because this is not upper motor neuron damage. So this is a very useful slide, very important. If you come across those particular findings, you will be able to differentiate very easily from those four groups, big groups: anterior horn cell damage, peripheral nerve or we call radiculopathy, myoneural junction, and myopathy. Do keep it in mind. So myopathy is a neuromuscular disorders. Actually, we should not mention neuromuscular disorder, but it is a muscle disorder where primary symptom is muscle weakness due to dysfunction of muscle fiber, not because of peripheral nerve or anterior horn cell or radiculopathy. If you get muscle involvement, it is not myopathy. So myopathy is a muscle disorder primary because of involvement of muscle fibers or dysfunction of muscle fibers. So it is a heterogeneous disorder where it can be metabolic or channelopathy or because of structural disorders. And the most common symptom will be malaise, fatigue, lethargy, and person will usually say just don't feel right. This will be the common presentation in case of myopathy. So history becomes very useful. Proximal are always more involved as compared to distal. Person will complain of fatigue. Person will say that because proximal is involved, so person will say that I find difficulty in getting up from chair or getting up from floor or getting up from tub, etc., which is suggestive of a hip girdle muscle involvement. Difficulty while climbing the stairs, difficulty with overhead task means putting an object on the shelf or getting the object from the shelf, etc. And if there is an intercostal muscle and diaphragm gets involved, person will have a respiratory symptoms and signs in the form of respiratory distress. If bulbar muscles are involved, then person can have involvement of speech, swallowing difficulty, oculomotor muscle involvement will be produced, squint, diplopia, and you can have even facial muscle involvement. This will be very peculiar in case of a myopathy. Fatigue, muscle pain, cramps, stiffness quite commonly. Stiffness will be more common in case of myotonia as compared to other group of disorders. Paresthesia and dysesthesia is not very common in case of myopathy, but sometimes person can complain of paresthesia and dysesthesia. But if person is having a muscle weakness with paresthesia, and if muscle weakness is more in distal as compared to proximal, always try to rule out peripheral neuropathy. And if the person is having a radicular pain or a root pain or neuralgic pain, rule out root compressions. Particularly we call plexopathy or radiculopathies. Always keep that thing in mind. So we already mentioned you can come across atrophy or hypertrophy or pseudo hypertrophy, which will be in favor of myopathic groups. Fatigue is a very second common symptom which a person presents. Myositis, vitamin D deficiency, statin and hypothyroidism will present with a muscle pain and cramps, quite common. So cramps will be another common symptoms. Contractures will be more common in a late stage of myopathic groups. In a myotonia, you will come across stiffness and difficulty in relaxation. And most important finding, no sensory involvement in case of a myopathic groups, as well as in myoneural junction also. So in physical examination, we try to find out the severity by, if there is no contraction, 0, power 0, flickering movement, power 1, person is able to move avoiding the gravity, power 2, against the gravity, power 3, against the resistance, power 4, and normal power we call as completely normal power. So try to find out the severity of weakness. So first we have to demonstrate and quantify the weakness. Look at the muscle bulk. If the muscle bulk is increased, it is in a dystrophy groups like Duchenne and Baker's. Palpate the muscle. Muscle will be usually flabby, and you might see even fasciculation, fatigue. Look for the muscle tone. Usually the tone will be reduced. Reflexes will be usually preserved, but in an involved muscle, reflexes may be diminished or absent, and sensory system will be normal. So muscle bulk, good number of time it is normal, but you can have a exaggerated, we have already mentioned in case of a pseudo hypertrophy, and wasting will be there in some of the groups of myopathy groups. Pain will be there in the myositis. Fatigue will be quite common symptom. Reflexes are usually normal. Sensory system is normal. So if a person comes with fatigue, always rule out neuromuscular junction or myasthenia gravis, lipid abnormality, mitochondrial myopathy, chronic myopathy, etc. If the person comes with muscle hypertrophy, then always suspect limb girdle muscular dystrophy groups, that is Duchenne and Baker's. Pseudo hypertrophy, that is Duchenne. Atrophy, very commonly in a fascioscapular humeral variety. Fascioscapulohumeral dystrophy, cervical humeral dystrophy, that particular groups. If the person comes with myalgia and there is a muscle weakness, look for local trauma, neuromuscular junction disorder, Duchenne muscular dystrophy. Contracture will be very common in glycolytic variety, and stiffness will be very commonly if there is an inflammation of joint, stiff person syndrome, and neuromyotonia. While person with myalgia but no muscle weakness in fibromyalgia, temporal arthritis will be another common. So do keep it in mind. So muscle disorders, sensory system is normal, reflexes are normal, proximal muscle more involved as compared to distal. You can have congenital and acquired. Among acquired, some of the example like vitamin D deficiency, statins, other drug induced autoimmune mechanism like polymyositis, dermatomyositis, and other paraneoplastic disorders, cancer-associated collagen group of disorders, connective tissue disorders, etc. Usually congenital is early in age, it is progressive, proximal, more common than distal. Proximal is more common in dystrophy, while distal is more common in myotonic variety. You can come across metabolic disorder, mitochondrial disorders, and channelopathy. Very commonly potassium disorders, hypokalemic periodic paralysis, which will be among congenital groups. Among acquired groups, maybe because of drugs, inflammation, endocrine disorders, electrolytes and toxins. D for drug, I for inflammation, E for endocrine, and E is also for electrolytes imbalance, particularly potassium imbalance, and T for toxins. So this will be among acquired groups. Muscle weakness, if it is intermittent muscle weakness, suspect myasthenia gravis, metabolic disorders, and potassium periodic paralysis, particularly hypokalemic periodic paralysis. And if it is a persistent muscle weakness, it is usually in favor of dystrophy, where you will have a proximal muscle weakness more compared to distal. And in case of myotonic, distal muscle weakness with difficulty in relaxation will be more common with myotonic group of disorders. Fatigue will be very common symptom in case of metabolic and mitochondrial disorders because of ATP deficiency. Contractures will be more common, and good number of time EMG will show you absolutely silent and there is no relaxation, and it is quite common in Embry Dreyfus dystrophy. Short form it is called ED dystrophy, Emery Dreyfus dystrophy, where contractures are quite common and there is no relaxation. Myotonia, there is a slow relaxation, and along with myotonia you will have home Addis pupil, and that is classical diagnosis of myotonica congenita. And there is another myotonica dystrophy. You will come across muscle stiffness, very common in SMS. Painful myopathy will be quite common in fibromyalgia, polymyalgia rheumatica, and polymyositis. Muscle hypertrophy, particularly calf muscle, very frequently seen in a Duchenne myopathy. Muscle atrophy will be more common in facioscapulohumeral. They also add also cervical, facioscapulocervical humeral dystrophy. And generalized muscle weakness and fatigue will be more common with potassium disorders, hypoglycemia, anemia, hypoxia, shock stage, magnesium deficiency, etc. These are the different types of myopathy. Baker's and Duchenne is proximal, or we call limb girdle variety. But limb girdle is another variety where you get a limb girdle but distal muscles are not involved. Calf muscles are not involved. But in this Duchenne, calf muscle is hypertrophic and you have got a limb girdle muscle involvement. While facioscapulo, you have got extraorbital muscle involvement, facial muscle involvement, scapular muscle involvement, and upper arm involvement. That is called facioscapulohumeral dystrophy. There is one another variety called as a distal muscular dystrophy, where distal muscles are only involved. And there is one variety which is called oculopharyngeal, where ocular muscle and pharyngeal muscles are involved with limb girdle variety of involvement. These are the different varieties of involvement. And Embry Dreyfus will be limb girdle variety, but in lower limb it will be a selective area of involvement. That will be, these are the 5 different groups. Sorry, it will be 6 different varieties. So depending upon the pattern of distribution, this will be more in favor of what we call as the myotonic groups also. You will have to rule out myotonic groups. So this will be Duchenne, this will be Emery diffuse, this will be limb girdle variety, this is fascioscapular, and this is oropharyngeal variety. So these are the common variety of muscular dystrophies group. The person will always present with proximal muscle weakness, progressive weakness, pseudo hypertrophy of calf muscle, spinal deformity, particularly lordosis, and sometimes even scoliosis. You can have a cardiac muscle involvement in the form of a cardiomyopathy. So there can be cardiopulmonary involvement, and there may be mild to moderate mitral regurgitation. So person will have a shoulder and arm involvement, sway back, then weak buttock muscle. So hip muscles are wasted, knee is bent back to take the weight. There will be hypertrophy of calf muscle. So contractures may be there, particularly in a tendoachilles. Person might have a foot drop, belly is protruded forward. So we call belly stick out, weak belly muscles, thin weak muscles. Person will have a poor balance and he will walk with a waddling gait, broad based waddling gait, typical waddling gait. And this will be classical in case of Duchenne myopathy. And person will be getting up from the supine posture, that is called Gover's sign. And person will have a lordotic and waddling gait. So that will be very high steppage gait. Foot drops will be very commonly if there is a peroneal muscle involvement. High steppage gait will be seen in that particular variety. This is in general. This is a typical Gover's sign. So person while getting up from the first he will acquire prone position, then he will take forelimb positions, then he will climb on his own lower limb and becomes erect, and then he will be walking with broad base waddling gait. And when the person is sitting, lordosis will become less. Almost we say disappearance of lordosis while in a sitting posture, because it sits very peculiarly. But as soon as he gets up, there will be typical lordosis with belly protruded. Very, very characteristic. You can see here first he will turn to the prone position, then he will get to the forelimbs, then he will acquire that, he will climb on his own limb and then becomes erect. And then he will walk with broad base waddling gait. This getting up from supine to erect posture is given a name, Gover's sign or Gover's maneuver. So person with muscle related symptoms, history, good examination and CPK along with TSH becomes very useful. CPK less than 10 times upper limit of normal, suspect myositis. Normal creatinine, myalgia. And creatinine very, very high, suspect rhabdomyolysis. So if a person has got myositis, the person will have a muscle pain, creatinine kinase will be less than 10 times, means less than 400. And if it is markedly increased, then always suspect rhabdomyolysis. So statin is more likely to produce rhabdomyolysis. So do keep it in mind. Intermittent weakness, myoglobinuria, if answer is yes, go for muscle biopsy. If intermittent weakness, myoglobinuria, answer is no, then depending upon the type of weakness, variable weakness, will suspect more of myasthenia gravis group. If there is in between the attack, proximal muscle weakness is more than distal muscle weakness, suspect myotonia, or we also suspect hypo or hyperkalemic periodic paralysis groups or paramyotonia congenita groups. So try to rule out those groups. So this is just roughly one algorithm where you can have intermittent weakness and you proceed according to this particular chart. If there is a persistent weakness, proximal more than distal, always suspect muscular dystrophy. If person has got ptosis, suspect myoneural junction disorders group. And there is also one variety where you have got mitochondrial myopathy variety where you can have ptosis. And if there is an involvement of the fascioscapular winging, then fascioscapulohumeral dystrophy. If you have got a difficulty in releasing the grip, suspect myotonic disorders. Proximal and distal hand grips and quadriceps are involved, then IBM, inclusion body myopathy. If distal is more involved, distal myopathy. If person has got droop head and ptosis, suspect myasthenia gravis, then hyperparathyroidism, amyotrophic lateral sclerosis, etc. groups. So this is another way of approaching. We already mentioned upper motor neuron, anterior horn cell, peripheral nerve, myoneural junction and muscle. Difference, inflammation, infection, neoplastic, toxic drugs, metabolic groups. So these are the diagnostic categories. What will be the finding? What are the disorders with upper motor neuron variety? What are the disorders with anterior horn cell disorders? Disorders with peripheral nerve, disorder with myoneural junction and disorders with muscle. We have to take care of these two groups. So always keep it in mind. Classification of myopathy. Inherited inflammatory myopathy, particularly polymyositis, dermatomyositis, inclusion body myositis and viral myositis. Muscle dystrophy, mainly limb girdle, fascioscapulohumeral, then scapuloperoneal, distal, etc. These are some of the muscular dystrophy. Myotonic disorders, particularly myotonic dystrophy. Congenital myopathy can be different varieties. Metabolic myopathy can be there, mitochondrial periodic paralysis, glycogenosis, metabolic myopathy. Endocrine induced, particularly thyroid, maybe in both hypothyroid as well as hyperthyroid. Parathyroid disorders can also produce adrenal gland, steroid induced, pituitary also. There are drug induced, particularly like statins and some toxic material also. This will be more in acquired group. Endocrine and drug induced will be more in acquired group. While all this muscle dystrophy, myotonic disorders, congenital, metabolic will be congenital. This will be congenital. Polymyositis, dermatomyositis, inclusion body myositis and viral, that will be inflammatory, that will be in an acquired group. That will be in an acquired group. Another way to remember vascular, I for infective, T for trauma, A for autoimmune, M for metabolic, I for iatrogenic and N for nutritional. Short form vitamins, whichever way you want to remember. And S for syndromic. Acquired group, inherited group. Inherited group dystrophies, which can be proximal, that is proximal limb girdle, that is pure limb girdle, myotonic variety, fascioscapulohumeral, oculopharyngeal and distal variety. Then you have got channelopathy and certain metabolic disorders, which can be mitochondrial, glycogen, lipid storage, etc. While acquired group, polymyositis, dermatomyositis, inclusion body, granulomatous, infectious myositis, electrolyte imbalance, endocrine induced, drugs particularly statin and steroids, toxic material like alcohol, organophosphorus poisoning, snake venom, etc. So this will be two division, inherited and acquired groups division. These are already we have mentioned: inflammatory, endocrine, toxic, drug-induced, paraneoplastic, inclusion body. Then this will be part and partial of, yes, endocrine and metabolic groups. This will be toxic, organophosphorus, snake venom. These are chloroquine, can also produce corticosteroids, amiodarone, beta blockers, etc. And even dermatomyositis can be paraneoplastic groups. And you can see among all this group, Duchenne is accounting for 23%, Baker's is 10%, so together they become 30 to 35%. Then facioscapulohumeral is 13%, limb girdle is 10, congenital myopathy is 7, myotonic is 13, muscular dystrophy is 3, spinal muscular is 12, hereditary neuropathy is 12. So this is a roughly distribution. Clinical features, I am not going into detail. Mainly person will have a muscle involvement, proximal more as compared to distal. Some has got distal more as compared to proximal. And depending upon the variety, you can have hypertrophy or atrophy. There will be no sensory involvement. Reflexes are usually preserved, but in the late stages they may be absent, etc. I've already mentioned majority of those. So depending upon the distribution, you will be able to differentiate different varieties. But person will come with proximal muscle weakness, malaise, fatigue, sensory symptoms are usually normal. Occasionally person might have paresthesia. Atrophy is very common. In certain conditions, you have got an increased muscle mass like hypertrophy, particularly calf muscle hypertrophy in Duchenne. Weakness, no sensory involvement, no sphincter involvement. Myalgia will be more common in case of a myositis. So myopathy symptoms, proximal more compared to distal, fatigue, difficulty in rising from chair, floor and tubs, difficulty while climbing stairs, then difficulty with overhead tasks, respiratory, even combing hair. Bulbar weakness may be there in some of the conditions like facioscapulohumeral or oropharyngeal variety. Pain is there in only very few cases, mostly in an inflammatory variety and metabolic variety, and you will have a high CPK level in those groups. We already mentioned all this nearly. At your leisure time, you can go through. And in particularly where you get a rhabdomyolysis, also you can have hemoglobinuria or myoglobinuria. Ideally, we use the word myoglobinuria, which will be very common when you get a rhabdomyolysis. Also, in case of a polymyositis, you can have a myoglobinuria. This is a difference between the different varieties of myopathy at your leisure time: dermatomyositis, then limb girdle, Duchenne, then facioscapulohumeral. This is CMD, DD. Then investigations wise, EMG will be very helpful. CPK enzymes will be helpful. Electrolytes to rule out electrolyte as a cause of myopathy. Then myoglobinuria. Then renal test, because myoglobinuria can produce renal damage, etc. will be useful. Genetic study will be useful to rule out genetic etiology. Then ECG will be abnormal in a person with a Duchenne and Baker's because of cardiomyopathy. Then there will be some test like forearm exercise test, 2 minutes, 4 minutes, 6 minutes, and then look for lactate and ammonia level. Both will be elevated in normal person, but no change in a non-cooperative person. If lactate is elevated or only ammonia is elevated, metabolic disorders, antibody will be very frequently present in an inflammatory myopathy. Muscle biopsy will help in acquired groups, more common, and some of the congenital groups. EMG will be very helpful, and also now conduction study will be helpful. Some of the condition can be also diagnosed by MRI. Muscle enzymes will be helpful to rule out inflammatory pathophysiology like polymyositis groups, EMG, now conduction study, etc. So I end my lecture here. This is in general a rough idea regarding disorders which involves the muscle. We'll be doing separately on myasthenia gravis, then polymyositis, etc. as we come across. So this will be helpful to you in your everyday practice. If you like this particular lecture, don't forget to press button like, subscribe, and you can share with your friends. Thank you all for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. And I feel this will be very helpful to you in your everyday practice whenever you want to differentiate pure muscle involvement from anterior horn cell, peripheral nerve, radiculopathy, and myoneural junction. Also, always try to differentiate from upper motor neuron type of muscle weakness. So this will be very, very helpful to you in your everyday practice.